Okay. If everybody just wants to do a little bit of an introduction on themselves in the chat, if they like. We're obviously all come along to these quite a bit, but it's nice just to say hello in the chat there. And we'll let sort of people jump in as we go, but may as well jump straight in with Nikki. Welcome.
Oh, mic's on. Kia ora, o tina tātou katoa, ngā mihi Petrea mo tō mihi kia mātou I tēnei rā. Ko Nikki Hatako ingoa no te tarawhiti aho engari papa I oia taku kainga nai nei, ka mahi aho te pau arahi mo Fielding Healthcare, paura tangata. So I'm Nikki, I'm the oh, thank you for your welcome, Petrea. It's really nice to be invited to these sessions, and I'm really keen to, attend more and hear what everybody else has got going on around the place. So yeah, thank you for that. Yeah, I'm Nikki. I'm the CEO at Fielding Healthcare, and today I'm going to be talking about phones, which I was kind of worried was going to be really boring. But I hope it's of interest to some people, and that we've just implemented a new system here that's been really, really great for our business, and it was something that I think will be interesting for particularly people, business owners and practices, and hopefully to those that are influencing practices as well, and sort of thinking about what's out there in terms of infrastructure and how we can work differently. It's really relevant to the sort of healthcare home model, healthcare Aotearoa approach, in that it's all about continuous improvement, about workflow, about patient satisfaction, quality of care, although, it's kind of a business and infrastructure thing. So yeah, I'm going to flick through it and try not to talk too long. There's lots and lots of detail I could go into, but I'm really happy to talk to people afterwards and provide more information. It might be best to chuck questions in the question chat thing, and then we can talk about it afterwards. So I'll save lots of time for discussion or not. See how we go. Good. So this is just a quick picture of us. Sometimes good to know I'm sitting in an office in there somewhere. This is our building in Fielding. It's quite a big building. It's about 2,000 metres squared. We've also got another site about 16 kilometres away from us, and we do general practice in these buildings, and we've also got a whole lot of integrated collaborators, partners that share a lot of our infrastructure, like our PMS and certainly our phone systems. So we've got about 30,000 people in the wider Fielding area, and this is the hub. So everybody comes here for a whole bunch of primary care services. And the key thing about this presentation is that our phone line is often that sort of first port of access. We've got about nearly 22,000 patients in all, so lots and lots of it's really
sorry, Nikki. I can't actually see your shared screen.
I didn't share it. That's fine. Hang on, let's try that again. Can you see it now?
Yeah, you can see it now.
Cool. I'll go back. This is us. That's what we look like. Don't know whether that's interesting, but anyway. So yeah, today I'm just going to do a little overview of sort of what we did and what our system was. And I want to say from the outset, no one's paying me for any of this, because it might sound like a bit of a pitch for an IT company, but it's not like that at all. There's multiple companies that would probably do what I'm going to tell you about, and I've got I'm getting no incentive for it whatsoever, apart from that I think it's a really awesome system. And it's not often that I've found IT or infrastructure that really exceeds my expectations. So that's why I'm talking about it today. It's a system that I think is better for everybody. It's definitely better for our patients, better for our staff, and really, really good for our business. So I'll just go through that. The reason, this is an issue for lots of practices, I know, because, I talk to lots of practices, and all practices struggle with their phone systems, not all, but many. It's a very common problem. Often we can't answer. And back in the early days of Healthcare Home, it was about getting analytics and actually answering phones. And we've got a bit better with that sort of stuff. A lot of practices are moving to VoIP systems or have moved to VoIP systems. For us, certainly with COVID, we just maxed everything out. Like we answer about over 100,000 calls a year annually. And with COVID, we, when the pandemic hit, we just got, probably 2,000 calls in about 3 or 4 hours, and our system just didn't cope. And then things sort of, I think as our patient base grew, we scaled up and up and up, and the system just wasn't coping. Our phone contract was coming to an end. We wanted more smarter ways to deal with things. People were sending us messages on Facebook and emails, and we had Manage My Health going, and there's just stuff coming in everywhere. So we knew that we needed to do something different. We were expanding to new locations, and we wanted something that would be easy to set up in different sites and in different business units, and just that sort of stuff. A lot of our team started working at home because of COVID, and the whole place became a lot more mobile, as I'm sure it is for everyone. Working at home is really important to staff. Patients started talking to us in all sorts of different ways, and for younger people, ringing someone up is the least preferred way to do business these days, and our business is expanding. So those are sort of our high-level strategic needs. The other issues that we had is that I always had a real bugbear with licensing, and that you have to buy all these licenses, and in practices you get Mondays like this, and then the rest of the time you've got this expensive resource that you're not using, that because you paid the same amount of licensing. So that was always a bit of an issue for me. We had we had desk phones and hardware on site, and the phone system was linked to a server that was on site. It's the only thing for us that wasn't in the cloud. Capacity, it was a VoIP system, but a lot of systems have these things called using these things called zip lines, and so they're limited. So whilst they're kind of operating across the internet, so to speak, they still have limited capacity, and for us that was a barrier. And the thing that one of the things that really bugged me was that every time we wanted to change something, we had to go back to our service provider and get hold of them, and then they changed and didn't know our sort of business, and I just found it annoying. If we wanted to change the voice messages when people called the practice, we had this complex thing where we had to upload an audio file and load it and yada yada yada. It was really, really hard to do, in my opinion. And I think, the other thing with this is that if you take the sort of quality improvement approach of what's the biggest issue in your practice, like everybody hated answering phones, to be honest. Like, it's a really big part of what we do, and it's so important to patient care. It's in my opinion, it's as important as the clinical care that they get in many cases, but it's just not much fun a lot of the time. And it was something that we just needed to pay attention to in terms of improvement, not just for admin staff. This goes right across the board. Clinicians spend heaps of time on the phone as well. So we looked at I did a little business case. I guess what I'd say about this too is that practices are small businesses. Like, you don't need to have a case that you might write for Treasury to decide on a phone system. So don't be, the thing I'd say to practices is don't go overboard with this, and trust your own instincts in terms of what you need for a business, because often we're getting advice from places who don't understand our business and have big expectations around the size of a case that we write, and get a bit overwhelmed. You do need a business case. You need to do the numbers and decide the best system for you. Write it down, put it through a couple of your owners or your directors or a board if you've got them, but don't go overboard or get overwhelmed by it. So I had a look around at other systems, and all the ones that the PHOs were promoting, and our phone provider had their own systems. The key thing that I did was that I spoke to actually a friend of mine who deals with big businesses who take heaps of calls. And so I thought, well, places like Vodafone and Westpac Bank, and just thought really big. And when I looked at those places, there was only really 2 systems that stood out that people were moving to, and I thought, that must be, I don't know where things are heading. So I took a bit of a punt on those and worked through the logic ourselves internally. Yeah, you can, again, I can't stress enough how overwhelmed you can get, because all the suppliers tell you that the other systems are terrible, and they try and sell you theirs, but you've got to use a little bit of gut instinct on that one, I think. And then I wrote a business case, which I'm really happy to share with people and take the numbers out of it, but in terms of the reasoning and all that kind of stuff, if anyone wants it, you're more than welcome. So we went with this system called Amazon Connect, and there's a link there. You can just Google it, and it, there's heaps of information on the online about this. And there's an agent. So this is a big global company, obviously Amazon. It's the same Amazon that we all know that does heaps of other stuff. And the agents for Amazon is Consigna. So they are the ones that helped us set it up, and they effectively sold us a system. That's the NZ agents. We opted for a data-only contract. So that means we've got no more licenses, which is awesome. So we can just set up anyone, anywhere, anytime to use our phone system, and it's just simple. It's all cloud-based. It's designed for, this is the bit that gets a bit scary, is that it's designed for a call centre. So it sounds big and bad, but it's not. I mean, practices, even small practices, have a call centre of sorts. There's phone calls that come in, and the system is primarily designed for taking incoming calls. Now that can put you off straight away, but I just urge people to sort of work through the idea in a practice setting, and that actually the majority of communication in a phone centre will be coming from internal to a receptionist, who then it ends in a task, or they book an appointment or something like that. So most of the communication actually ends there. So you don't need to be scared off by the fact that you can't. I can't pick up my desk phone now and ring somebody up on my desk phone that's in the office down the hall like I used to. So I'll come to that later. But what it does do is that all the call centre operators, which are your receptionists or patient services team, they can transfer calls to. There is a process for transferring. So I guess what I'm saying is, if you have a look at this, don't be scared off by the fact that it's called a call centre. But the key thing about this is that it's an omni-channel, and so it deals with communication in all directions, web and phone and email and et cetera, and it's a great platform for managing all that sort of stuff. The way we changed was that we kept the old system in place. So I guess what I'd say from the outset is I'm petrified by phones. I will do anything in business, but phones just freak me out. There's just so much that I felt could go wrong. So I decided to keep the new system for 3 months. The old system for 3 months as a bit of a backup, and then we adopted the new system. So the first thing we did was that we switched over all of the incoming calls to be answered by the new system, and that was the first phase. And then the second phase, which we did about 2 months later, is that we literally just went around and picked up all of our desk phones, and we got rid of our internal calling functionality, and we switched all of our internal communication to Microsoft Teams. So now if I want to talk to someone internally, I just get my Teams app and bring them up wherever they might be. It takes a little bit of logistics, in that you move from, many practices will say, we'll ring rooms, so they'll know that room 2's got, direct dial 202 or whatever. You've got to shift from that to ringing roles or people mostly. For the most part, that's been an awesome change, and it's been a really positive change in the way that we do business. The things, I think this is the really key bit in terms of how does this help patients. The key thing about this system is that it's so smart and it's so flexible. And so our patients now can self-select. So, all of that stuff, again, back to Healthcare Home, where the reception team will be going, is it ACC or is it forms or whatever, you can you can set your own, like I can go online now and I can type into a sort of a call flow. It's got this beautiful voice, so it's not my voice or somebody else's voice that's recording the messages that patients hear. It's one of those nice voices, you know, that you hear when you ring Vodafone, and you can set whatever flow you like. So for example, we've just made a change which has increased our patient satisfaction. It's gone up from 92 to 95%, and I think it's just based on this change because I don't see anything else that's worked. Where we ask patients to, you know, tell us whether they ring and it's like, you know, welcome to Feilding Healthcare, etc. They choose between, is it urgent today, is it routine, is it for forms, and is it respiratory? And then we give very specific information. So for example, if they select respiratory, they get a voice that tells them that most respiratory symptoms can be managed at home, etc., etc. And this is clinical information that's been, you know, signed off by our clinical teams, etc. And then the next step that we're working on for that flow is they'll get a text that says, you know, before making an appointment, unless you've got these two symptoms, in which case you should get an appointment sort of thing, it can text out and give them a Healthify link. So that's kind of channeling patients to self-manage, providing information, but if they're sick or still need an appointment, they just hold the line and they get that. So that's been really, really good. And the thing that is very helpful, this is detail, but I think anyone who works in a practice will understand this, how helpful it is that once they select, there's this thing called a whisper function. And so, for example, if they do select respiratory, I'm sick, it's urgent kind of thing, it will go through to exactly the right person and it whispers in the call taker's ear that it's like urgent respiratory. And so if I'm answering that call, I know that that patient's already said, I'm sick, I've got a respiratory problem and this is urgent, and then they answer the call and deal with it that way. So yeah, that's been really, really awesome, and it provides people with information. The callback function has just been a game changer for us. I mean, people might be using this around, but I'd never used it. The patients, if it's not urgent, we can just set a message to say, you know, we're really busy, it's Monday morning sort of thing. If it's not urgent, you won't lose your place in the queue, just push the button and you'll get a call back, just like you do. I mean, you would have used this in lots of other services, and it sounds clinical and not clinical, but it sounds what do you call it, a bit formal, and you know, not, and people would rather just talk to someone. But I can tell you our patients really like this. It sets expectations. They get a call back when it suits them. They know when it's coming. They're not just waiting around for a call back all day from somebody to triage them, all that sort of stuff. So the requesting the callbacks are great. The text-to-talk function allows us to give patients information in real time. So, for example, if it's a really busy Monday morning and there's, you know, appointments are all gone by 10 o'clock, we can quickly change the front end message to tell people that, you know, that it's exceptionally busy. We've got a couple of GPs off. Don't forget we've got video consultations. Try Practice Plus, just whatever's relevant for that day, because it's dynamic in a practice that it can change really quickly. So we provide patients with that information up front now, rather than waiting to talk to someone and then having the conversation, etc. It's really easy to scale. We openly use New Practice, and we literally just set up the whole New Practice with telephone systems from our computer within about an hour. The headsets are great. You're probably using one of those already, but the noise cancelling headsets that come with this system are, you know, everybody likes them. There's lots and lots of features around the setup that are customizable. So, for example, one thing that's been really helpful from a training perspective for clinicians and admin is the ability to listen in on phone calls. So if somebody's triaging a patient, or if there's a new receptionist training, they just chuck on a headset and can listen to the way that somebody else deals with it. And lots of old systems, you need to set up admin rights and all kinds of stuff to do that. But in this, it's very customizable per user. You just tick a box and say they can have this and not that and this and that, which is great. And there's a really, really good dashboard that pops up on everybody's computers so that you can kind of see the whole business virtually. And if people are working at home, you can see what's going on. And it's not because you want to monitor them or be Big Brother. What it does is creates a team environment where you can go, oh, they're really busy, or they're struggling with this. So let's help them out. So it's brilliant for the sort of virtual situation. And the next features that we're going to adopt are the sending out more text messages to patients depending on what information they're wanting. And so that's on the phone system. You'll see a lot of that on like your power providers and things like that. If you ring up and you want to get your power cut off, they'll be like, are you ringing about getting your power cut off? Oh, you can find that online. Here's a text message, or otherwise hold the line to talk to us, kind of thing. So there's lots and lots and lots of repetitive requests for information and practices that where you don't need to talk to someone, and you don't need to, people just want information, or the web chat is a really big one. So we want to, a lot of people are messaging us in all directions at the moment because they would rather do anything but talk to us on the phone in lots of cases. I know that sounds weird, but for anyone that's got kids at home, under 20 or even under 25 these days, that's just the way of the world. So we're sort of getting ready for that, and we're catering to that market. The AI is really good. So this system holds, it records all of the incoming calls and holds them for about 2 weeks. So these are calls that would normally go to a reception team. It doesn't record outgoing calls from clinicians and all that sort of stuff. But and then we can analyze it. So we can tell the system to find all of the calls that had the word prescription in it, for example, and it listens, and it can create that into a text, and it can say, you got 400 calls with the word prescription in it, with that sort of thing. So it's really, really clever, and we can work out themes around what's coming in and what we need to respond to and how we can do things differently, just to understand the needs of our patients better. We still have a prescription line, and so what this system does is it turns the talking on the patients leave messages on our prescription line, and it turns it into text, which is really good. So then the nursing team don't have to be listening, and they can't hear it, and then they call people back and all that sort of stuff. So instead now people ring our prescription line and it says, tell us what you need, and then it kind of steps you through it, and it turns it into text, which has been a really, really awesome thing. And then our next step will be integrating the system with MedTech Evolution. So there's some work going on that at the moment. Actually, I'll just jump over to the benefits, because I think I'm skipping through a lot of this, but there's been so many benefits to us in this really early on. And I think, it was really obvious in our patient communication. They just feel better about the service they've got at the end, because it was probably smoother from the outset. And we just shouldn't underestimate that those first interactions with your health centre, and how important they are to the overall quality of care. And so I think patients really, really like it. It gives them better communication, better information, realistic expectations, and it channels them to the person they really need to be talking to. For staff, like this, honestly, the stress levels have just gone down. It's it just feels different, and things are more manageable. There's less calls to manage. The right staff are responding to the right things. This will be one that the business owners will like, is that the cost, we've saved a huge amount of money on the system because of the shift to the data-only contracts, and we're just not paying for staff. And when I say a lot, it's probably cut our bill by a third easily, which for us is tens of thousands of dollars a year, and that's money that we can invest in other areas. So that's where we can use it to be adding on the new features and doing other cool stuff, which I really love. And it certainly ticks all the boxes when you think about that quadruple aim in terms of better patient experience, better outcomes. Clinicians like it. The idea of clinicians getting rid of their desk phones is really scary for a lot of practices, but I can tell you it was pretty smooth. Like, it wasn't anywhere near as scary as what we might have initially thought. And oh, sorry, I'm just going to go back. And I think the lessons learned for me is like, don't be scared to try something really different when it comes to phones, because they're kind of one of those things that people get really nervous about. Or maybe I'm projecting, because I sort of things that I get nervous about. And right up until the end, I was still saying to the team, like, what does that mean? If I pick up that call, then is that going to ring someone over there? Will that phone number still work? And just asking really dumb questions like that. But just don't be scared of it. Make sure you talk to your IT provider really early, because there's lots of little bugs in the whole IT infrastructure that need to be at least understood. Not bugs, but things that your IT provider are about to point out that you might not necessarily think about, and the phone provider won't necessarily highlight to you. So just bring them into the team that's doing the change. I would encourage you to learn call centre lingo, but don't worry about all the tech speak that should say speak. And in many cases, in my opinion, it's better to stay naive and not try and be a techie, because it's their job to help you understand it. And I mean, if you can't understand it in lay people's terms, then there's no way you're going to sell it to your business. So do learn the call centre lingo, because that's helpful in my opinion. There was a bit of stuff around privacy that we were nervous about. We just worked through that and got some, made sure we had all the right information around whether or not the data cloud net health IT security standards and all that sort of stuff. And that's relatively easy. You just got to ask the right questions. Other people will tell you, oh no, that's, like, I was told by lots of people, oh no, that system won't meet privacy standards, etc. But people are just make assumptions and are naive, because it's not a commonly known amongst practices system. It's a big system across the world that stores all kinds of data, including stuff from the Ministry of Health and that sort of thing. So don't be scared of that. Just work through it yourself, and and reassure yourself through good evidence that it's ticks all the boxes. And then the other thing I'd say is that old dogs can learn new tricks. And by this, I'm talking about people who have worked in your practice a long, long time, and you could never imagine them shifting to a new WYSI phone system. They will, and it's it can be really easy. So those are the lessons from me, and that's all. Yeah.
Amazing. That was great. It's so interesting to hear sort of what other places are bringing in that's working quite well. I did just have a quick question. So when people call up, they're like, okay, is this urgent, routine, etc., etc. So obviously routine would just go through to reception, but urgent. So is there sort of like, let's say, a dedicated clinician on the phones for the duration of the day answering those urgent calls?
Yeah, so most of the calls still go through to reception, but they go to the team that so they still go through to reception, and then they'll get booked in. They'll typically just get booked for a GP triage. So all of our GPs do triage every morning, and then or a nurse triage if the GPs get full, or sometimes they end up in respiratory. Yeah, so there is a pathway, but they still do almost all go directly through to reception. Mm-hmm.
Oh, amazing. Did anybody else have any questions on sort of how this works, or what other changes this has made for the Feilding Health Centre? Look, I've got another one just while we're here. So the whisper function, because I find this very interesting because I had quite a lot to do with the phones when I was in practice myself. So the whisper function, so if I pressed urgent respiratory, so when the person who's answering it from the clinic, it whispers to them what
Yes.
the call, that is quite interesting. Can the patient hear it?
No, yeah. And so it's also really helpful if you can set that for anything. So for example, if you had a clinician taking urgent calls somewhere, or only doing respiratory, or even things like, I mean, you could tell it to whisper anything. You could have, cervical screening, or any identifier that you want, it'll whisper to the person receiving the call. Yeah, it's really, really helpful because it prepares them for what's coming and provides a better experience for the patient. Yeah.
Excellent. Can you see the chat there? We've just got a question or two in there. I can read them out for you if you like.
Yeah, I got it. Sorry, shall I just answer?
Oh, sorry. Yes, what are the GPs using if they no longer have desk phones for outbound calling?
So the way that the GPs work, once we work through the logic, that they can call out from the system. So they log in and they just have external calling ability. So they'll if they're bringing patients, they'll on one screen they'll have the patient palette and they'll just dial into the new system the phone number and that'll dial out. So that's for their GP triage, etc. And then they've got a whole list of commonly used numbers they can access, which tend to include things like, pharmacies and radiology and specialists and all that sort of stuff. So if they want to dial out from our system, they do that, and then they can, add new numbers in there if they want. They receive, the call centre can transfer calls, but only to cell phones for doctors. So we decided, do we need to be able to transfer calls? That was a big thing. And using our phone system. And most people thought, oh no, we can't cope without being able to just lift the desk phone and ring 2316 and know that, Dr. Bruce will be down in that room. And we found, so the way we would do that now is on Teams. So if I wanted to talk to anyone in the whole centre, I can just do that through Microsoft Teams, which is great. And the reason that's great is like if new staff start, I can type in someone's name or I can type in their role and it'll bring them up on Teams and I can see who they are and where they work and all that, in the organisation. It sounds like we're huge, but this would also work for a smaller practice because staff do come and go. So the GPs use Teams to contact people internally, so they can dial healthcare assistance if they need a chaperone or something, or whatever they like. And
so just a follow on from that one. So if reception wants to transfer it to a GP, previously that would have gone to their desk phone. Does that kind of just call on their computer now? Or did you say it goes directly to their mobiles?
No, it calls on their computer unless they've got it diverted to their mobile. Yeah. And there's a whole lot of ways you can set, that's another nice thing about the system is that there's a whole lot of ways you can set your computer to tell you that there's a phone call coming through, or you can just turn it off and not take it at all, really in quite sort of simple ways. Yeah. So that's been pretty straightforward.
Oh, fantastic. I've got another question here. So how did you get buy-in from the whole team? Was it a staged approach and what were the challenges from the teams?
Yeah, so it definitely was a staged approach and it was, how did we get buy-in? It was, I mean, to be totally honest, on the back of COVID, we were sort of in a bit of a phase of just like, oh my God, something's changing. So we kind of need to change it. So it was a slightly different, I would say, context, and people were used to changing quite quickly. So in some ways it was kind of like, phones are changing. This is when it's going to happen, and people were quite accepting of it. I don't think I had to sell it as much as what we normally would. But otherwise, it was really just. I'm just trying to think I was trying to think back to the change part of it. We spent quite a lot of time. I think that having the system set up as a training system was quite helpful, and we got all of the patient services and reception team trying out all the cool new features. So they're quite, a lot of them are they're really interested in techie sort of stuff, and they love the whisper things, and we tried all the new stuff, I guess, and they really liked it. So that was a really good way to buy in. They liked the transparency and the online training ability, and so I guess we probably sold all the key features. With the clinicians, it was more about addressing what they were worried about, just like, what are you worried about with getting rid of desk phones? What do you think you won't be able to do? And working through all of those questions and just making sure we had all the bases covered, and that there wasn't going to be any things that they wouldn't be able to do. So it was reasonably straightforward, to be honest. And then once we adopted the system, we spent quite a lot of time promoting what was going well with it and saying, we've had this new system and here's what's worked. And so sort of selling the benefits was really good.
In that 3-month changeover between the old and the new, did you continue using the old system for the patients calling in, but then were trialing the new system internally?
It was mostly outgoing calls that we kept the old system for, and so the desk phones and that sort of stuff. And so no, we pretty much got rid of all of the old system straight away for when people were ringing in. So pretty much we ported that whole number where people phone our practice over to the new system. It was really, really straightforward. Like, I thought the whole thing was going to break, and it was just like nothing happened. It was really, really good.
Yeah, because I could imagine that would be such a stressful time, like that sort of when you're like, okay, what if no phone calls come through?
Is it, I'm kind of interested if it's an issue. Do people see it as an issue in primary care with the practices that they work with? Like, is it a thing that is
call
a
management?
problem? What's that?
Call management.
Yeah, like, do other people recognise it as something where we can make massive improvements?
It does, like, from my personal experience, it does come up a lot. Just the demand on the reception teams for the amount of calls that come in. And then, then if you're sort of doing the GP triage, which obviously helps, but still such a massive demand. So it's still just phone calls coming in every which way. And you sort of just, you are diverting it to manage the demand better. But like, it is definitely something that I've come across it multiple times from practice and PHO. Does anybody else have any comments on that part?
Yeah, I will. I think that what I've heard is that you're getting an awful lot of communication coming in, and you found some really good ways of being able to give information back out to your patients without having to do it on a one-to-one personal basis, which actually saves an awful lot of time in the practice and makes sure you're getting really consistent information going back to your patients as well. Sounds really, really cool to me.
Exactly. Consistent information is a massive benefit, actually. Yeah, you bang on there. Yeah.
Yes, I can see it as a huge resource saver for practices, but there's always that, and you're quite a large practice, and I can see how for a large practice they could easily, well, not easily, there's a lot of work to move to it, and can see the benefits. I'm wondering for a smaller to more medium practices, how, from a cost perspective, so I'd be really interested in the costs for practices as well. Yeah, I think it's got a lot of benefits and can certainly help to save a lot of time in general practice. Yeah.
So it's called Amazon Connect, was that correct?
Yeah.
Yeah, because it'll be quite interesting to look into. Did you get any complaints from patients on the changeover?
No, we got a compliment. It's the first time ever I've got a compliment on our phones, and someone wrote to us and said that it was really good that they were able to make some selections, and which was astounding because I hardly ever get compliments anyway, let alone one about our phone system.
Yeah. You
So,
can
yeah, it was really good.
laminate it on the wall, be like our first phone compliment.
Yeah. The prescription line message, people were a little bit confused about that at first and thought they were talking to a real person, but it was the robot. So I guess that's both good and bad, but they sort of got used to that.
Excellent. Well, I mean, if nobody else has any questions, it's just been amazing having you come on and getting to hear you talk about Amazon Connect. It's been really interesting. If anybody does have any questions, you can still chat them through. Nikki will be online for the remainder of the session. Now, Renee and her team won't actually be starting until 11:15. We're just waiting for, I think it was Bronwyn to come in. But I'm just going to pass over to Leanna because we do have somebody else here, which is always amazing.
Yeah, hi everyone. I might, if it's okay, Nikki, I'll just get you to stop sharing your screen.
Yeah.
So we do have a little bit of a gap before the team, Renee and her team are starting. So luckily, Karoria has just jumped online with us and she's going to do a wee check-in for us. So those of you who were on our peer session last month will recognise Karoria. She's one of our amazing lived experience advisors and on our collaborative Aotearoa board. And those of you coming to conference, oh my goodness, only 2 weeks away today, we'll get to see Karoria as well. So no mai haere mai Karoria, thanks so much for joining. She's going to do a wee check-in for us. You are on mute. Oh, there you go.
Yeah, aroha mai, that was operator error. Kia mihi kia koutou katoa, ko waio, ko Ngāpui te rarawa me te Paurina iwi, ko Cable Bay tai tōkero, toka kāinga ina nei, ko te whare tapu o Ngāpui toka tūranga waiwai, tihei Māori ora. Kia ora, I'm Karoria. I originally started my journey with Collaborative as one of the lived experience advisors, and the role, like Collaborative, has evolved and grown. And I'm kind of, I shared time with some of you last month, and it was amazing. I really enjoyed that time. And I guess what I was just wanting to do, first of all, was just touching on the hauora aspect of what we do. And that kupu for me is incredibly powerful. It's ora, breath of life, right? So I'm first of all going to invite those who can to participate in a bit of a breathing exercise, which I found is really, really useful. Lovely way to kind of check in and get present in the room. And all it is following me along with a breath in, a breath out, a breath in, a breath out. So for those who can stand, I find it more comfortable. So it's simply ha ki runga, ha ki raro, ha ki roto, ha ki waho, ha ki runga, ha ki raro, ha ki roto, ha ki waho, ha ki runga, ha ki raro, ha ki roto, ha ki waho. E noho whānau, kia ora kia koutou. I just find that's a wonderful way to just ground myself in a virtual room when I'm working with people, and I hope you got some benefit out of that too, because I think we forget sometimes the power of that deep breath, you know, that and the letting go. There's an interesting study that I was looking at recently that smokers, if you ask them to breathe out and then you get them to stop, and then you put your hand on their belly and you ask them to really push out, most of them are holding a minimum of 1 litre of air. And so for a lot of smokers, it's not the breathing in, it's the letting go that's the issue. So yeah, just a little side thought on the heart. And again, we were talking last month about hauora for ourselves as carers. And I watched another webinar recently where they spoke about how do we resource ourselves. Where are the resources that we get? Where's the tautoko for us, particularly in the community and NGO spaces, because there's no real clear role. You don't just shut the door at the end of the day and go home. It's your whānau, your community is your work, you know. And so I've been learning a bit more about what people do to resource themselves. And
I just keep the
when you think about filling your own cup so that you can fill others. How is it that you resource yourselves? What are the things that work for you? And do you share or inquire as to that information with your colleagues? Because the wisdom that I got in that group was amazing. I learned some really cool. So, oh yeah, that would work for me. So I'm interested to, and if you can, I'd love to see them in the chat, because some of the also some of the themes that came out from listening to that webinar were incredible. There's a fantastic podcast that's just, it's I don't know how long it's been going for, but I've just found it because I've only literally found podcasts recently. And it's called Tatou Tatou, Tatou, Tatou. And it's hosted by a place called Hui, which is HUI, separate word E. And so the Tatou Tatou podcast, you can find it on Spotify and Audible and all of the places. But it's literally about caring for ourselves as kaimahi. How do we keep our own cups full so that we can fill others? And there's some amazing insights, because there's people from Pacifica and Māori organisations, and the woman who runs it is a bit of a star as well, Tui Hana. And yeah, so if you're interested in that kind of thing, go and have a listen, because it was also interesting for me to hear the very different approaches that some of our tangata moana, Pacifica and Māori kaimahi took versus some of my other colleagues, right? So yeah, it's very interesting podcast if you're looking for some inspiration. The other thing that's come up for me, having listened to another couple of these podcasts and thinking about matariki and what I'd like to let go of, is the concept of slowing down to speed up. It's a really interesting kind of social experiment that I'm doing at the moment with my colleagues, because a lot of them are in the business of busyness, and it's very, very busy. And I'm finding it, because my work is not from a clinical space. My work is from a lived experience space, and thinking about that Hei Tiki wisdom, the wisdom for those that weren't here. I believe that Hei Tiki, as the original child of the universe, has a really implicit wisdom that he shares simply in his physical form. And that's to remind us that all of us have primarily 3 types of wisdom: the wisdom of our heads, the wisdom of our hearts, and the wisdom of our puku, or our instinct, right? And that's and a lot of the places that I work in, people are very, very much in the head space. And then some of the other places I work in, they're very, very much in the heart space. Whereas because I'm a lived experience person, a lot of mine is very instinctual. And so I think that's one of the beautiful compliments that I can bring to enhance the mahi. But I wonder how often we walk into our spaces and consciously decide to be more mindful and to use the wisdom that we all have in all of us, right? Not just this part, because I get a bit lost up here. So, you know, that slowing down to speed up, what I found is that actually by sitting back, checking in with the 3 wisdoms that I have, and trying harder to bring my heart energy and my instinctual energy into that room, it means that I can do more by doing less. It means that I can ask better questions, so I can support others to lean into a bit more of their tacit wisdom, as opposed to their learned wisdom. I hope that makes sense. And so, yeah, that slowing down to speed up and that engagement of all of the wisdom that my body carries has been really interesting. So, yeah, I just want to kind of leave that with you in terms of slowing down to speed up, because I think we get caught up in the business of busyness. And, you know, like literally, I said to someone the other day, and I literally stopped a meeting in its tracks, because I simply said to them, but is this the right thing to do? Is this the right thing to do? Is what we're doing the right thing to do? Never mind all of the other stuff. Is it the right thing to do? And they had to stand there and think about it. And it was quite interesting, because it generated another kind of conversation. And we got there in the end. But, you know, being able to sit back had given me the capacity to ask better questions in that space and support them to get there. Because, you know, uaka eki noa, right? So, yeah, just thinking about that the energies for me this month have been around slowing down to speed up. And the other thing I find in that space for myself is that my whakapapa is all about being a journeyer, being an explorer, being a navigator, you know, whether it's the moana or the ngāhere or the spaces we move in, it's all about being that explorer. So when I sit back and I'm a little bit more slow, I find I notice the tohu or the signs that are trying to guide me much, much more mindfully, I guess. I guess it's just another form of mindfulness, if you want to think about it that way. So just being able to notice the signs, being aware of how other people are reacting, responding, you know, it's kind of given me space and to connect, I guess, more deeply with what's going on around me and the people that are around me. So yeah, again, being more present is another presence in those spaces, right? And I wonder how often, you know, I reflect on how much I'm rushing through things. Am I present? Am I there in my entirety? So these are just kind of, you know, because obviously all of you have your own wisdoms and your own experiences, but I'm hopeful that this might give you something to reflect on in terms of where you're up to right now and whether any of this can be a way through to resource yourselves, right? Because we are the micro of the macro. You know, just simply by being here, we're enough. So we're the, you know, whatever it is we're doing here will be reflected in anything that we produce. And so if we're not taking care of ourselves, if we're not nourishing ourselves, are we nourishing others in a sustainable way? You know what I mean? If we were really a genuine micro of the macro, then does what we look like or how we behave towards ourselves reflect the aspirations that we have in our mahi? And if not, where could I make adjustments, right? So these are some of the contemplations, I'm going to say, that I've had in the last month since Matariki. It's been quite the month. I'm sure you can all agree. Now, first of all, I should check in. Does anyone have any questions, queries, or feedback on what I've had to say so far?
Claudia, I was just noticing in the chat that Jontel mentioned that she goes for a walk on the beach with her kuri every morning, lunch and after mahi. That helps her. I just wondered if anybody else had anything that they do every day to take care of their mindfulness. I know sometimes you're forced to stop and do something for yourself, but it's those things that we probably make a habit of that actually make a difference. So that's awesome, Jontel, that you do that every day. Does anyone else have anything that they do on the daily? I think sometimes as women, we're not very good at this. Looking after ourselves or talking about ourselves.
Very much.
Lucy's got here, playing some music helps me be mindful either on the ukulele or piano. Awesome, Lucy.
That's epic. That is epic. Both of those suggestions are epic. They're both things that I'd love to be talented enough to play the ukulele or the piano or indeed any instrument. But yeah, no, music's huge. Music's huge. As you all know, you know, it's like, right, I'm going to the gym, I'm going to put this sound on, or I'm going into a space where I'm going to go relax, I can put this sound on. So it's a really good way to change.
Increased our patients,
I guess, your physical state, because in that really centered place, you know, there's the way your body feels, you know, and a good example of that is something that hit really hard because I keep reflecting on it, and every time I get a different wisdom out of it. I was told when I was very young, the only difference between excitement and fear is breathing. The physiological response is the same, the neurological response is the same, but the breathing determines whether it's a fearful reaction or an excited reaction, right? And so understanding that kind of mindset, I guess, and that physical feeling and your emotional feeling, those things combine. When you're standing in that place of those three things being solid, the tripod is the first stable shape, right? So, you know, just checking in with those things, and music is such a good way to change the mindset, change the physical feeling, you know, it's so good. Love it. Sorry, I'm not very good at running teams, in case you hadn't guessed by the way I
No,
talk.
but Patria's just popped in there saying that she's been trying to go for a walk outside before work or after work. I think that that fresh air movement, that kind of thing, makes a big difference, especially because I know lots of us are sitting a lot, sitting at our desks and sitting in front of computers. So Patria, I'm not sure, we've still got a little bit of time before the ladies from Renee and her team are joining us. Did we want to have a bit of a break, go and get a cup of tea and come
Yeah,
back? And
that's what I was
yeah,
thinking. Perfect
yeah.
time for
Is
a
it okay with
wee
you,
cuppa.
Claudia?
Aye, perfect.
Thanks so
No, that's
much for
great.
popping in. It's always nice when you can pop in with your pearls of wisdom and just make us check on ourselves as well. So, Kapa, and thank you so
There
much.
there is just one more thing I wanted to
Yes,
offer up to
absolutely.
all of the whānau here from across the Motu. One of my other part-time roles, I actually work for Healthify, the Health Navigator, supporting by the Health Navigator Charitable Trust, and we've just come out with a whole lot more resource available for pharmacies, practices, schools, maraes, whatever. I just happen to have one right here because I'm making some packs up for some people. And they're kind of some new posters that we've got with the QR codes. So people can go straight there and have a look for themselves, get some clinically reviewed information and things. So if there are any of you wanting, I mean, this is just one example, of course, but if any of you are wanting resource from us, please let us know, either get in touch with me or one of the team over there, and we can sort out some resources for you to make your walls a bit brighter and give people something to do and while they're sitting in the waiting room and so forth, etc. So let us know, and ngā mihi kia koutou. Thank you so much for your time. It's always a pleasure. Always a pleasure.
Thanks so much. Thanks so
Kia
much, Claudia. I might
Kia
grab
ora.
that QR code off you later and I'll pop it in the chat for anybody that wants to jump on and grab some more resources. So
Yeah, new resources for reception and the waiting room's always welcome,
absolutely.
I've found. Yeah.
Yep.
Yeah, so
Awesome.
Patria,
No,
should we take like a 5 or 10 minute break, go and get a cup of tea and come back, and then we'll catch up with
I think
Renee
that
and
would
her
be
team?
great. Yeah, so if everybody just wants to jump on sort of about 10 past, and then we'll, just get together and listen to the Marlborough Primary Health, it'll be great.
Awesome. Thanks,
Excellent.
Claudia.
See you all
Kia ora.
soon.
See you back shortly.
Oh, hello there. See a few people are jumping back on. It's always like it's only sort of 2 hours, but I always find like if you've had quite a busy morning, you get halfway through the 2-hour meeting, you're like, actually, I could really just go a coffee. So I do love we managed to fit a wee break in. All right, let us get going. So thanks so much for Nikki and Claudia for speaking already today. Next up, we've got Marlborough Primary Health. So we've got Renee and Megan. I don't think Bronwyn can make it now. So I will hand over to them.
Kia ora, tēnā koutou, ngā mihi nui to the collab for inviting us today to present what we're doing here in Marlborough. Our Marlborough Care Coordination team consists of 3 coordinators, myself, so I also lead obviously the healthcare home delivery in Marlborough. And Bronwyn, she's works in ED as a social worker, and she's actually with a critically unwell patient at the moment. So obviously she sends her apologies for missing the presentation today, but I'll let Megan introduce herself.
Kia ora everyone, I'm Megan from work at Marlborough Primary Health, and as Renee said, part of the care coordination team here. And thank you very much for letting us share just what we're doing here in Marlborough with you today. That's great.
All right, can you run see that second screen, just making sure it's all working? Great.
Okay, you can hear us all okay? All good?
Yeah.
Lovely, okay. So just a little bit around our story or our journey with care coordination. In 2019, Nelson Marlborough, the District Health Board, they were doing some work around models of care, and there are quite a few models of care that were developed, and one of them was around strengthening coordinated care, including healthcare home and strengthening coordinated care, locality care coordination. So that was quite a big piece of work across the district, and so we got a contract. Nelson Marlborough got a contract for that, and it was, I think, towards the latter part of 2019. So the model was launched, and then, of course, early 2020, COVID-19, which we all know about, which kind of interrupted and disrupted everything we did, and we were very much, setting up CBECs and like everybody else involved with the response to COVID-19. The kind of, I wasn't involved in care coordination at that time, but they were kind of looking at the care coordination role in regard to COVID and how that might support people with complex needs in the community. But it was probably more 2021 that we got quite a lot more traction around implementing the model of locality care coordination here in Marlborough. We have a real focus at that time on fostering holistic patient-centred care, and we'll go a little bit more into that later, show you how we've done that. 2022, last year, we're using quite a lot more access to data for identifying proactively people for care coordination, strengthening our networks, really communicating with our wider networks, supporting collaboration and looking for greater coordination around care and services to support patients in whānau. This year, 2023, sort of building on that with integrating Hei Pāhara Kiki with locality care coordination, and we've come kind of care coordination, and we're looking towards more support in the motor neuron disease, people with progressive neurological disorders. So what is care coordination? Just briefly, sort of overall, people with complex needs that often require lots of support, lots of care from different health providers, services, organisations, all going in to support them with their needs. But often those services and providers are doing wonderful jobs, but it's not connected and it's not coordinated, and it can become fragmented, and it's not, it becomes quite complicated for people, and so it's not really a patient-centred approach. So care coordination is working with providers across health, social, community to all work together so that it enables coordinated care for the patient in their whānau.
Yeah, and look, Hei Pāhara Kiki is now part of care coordination. So the strength in that is linking community teams and health care providers to better support our pipi, our whānau, and our hapu wahine. Now, for those of you that don't know about Hei Pāhara Kiki, it does focus on the first 1,000 or soon to be 2,000 days of a child's life. It is a critical period for a child's overall development and future well-being. So the aim is to support parents to develop positive, nurturing and healthy relationships with their pipi to create a wonderful future.
And just care coordination, we're not an urgent service. We're definitely not an urgent service, and so it does take time when we do get referrals around the pathway forward. So this is a step care model, which is from our contract, and we kind of, care coordination works across the continuum. So from our enrolled population, a healthy population, right through to the multi-service team. We've got people with really high complex needs that require specially individualised, personalised care plans across services. So, you know, an example of that was recently we had a care coordination meeting for a person with motor neuron disease who wanted to be able to stay at home, and that required quite a big care plan, care team, all knowing what their roles were, what they were doing to help support the person and their family were very actively involved in that as well. So who can be referred? It's basically any of our population that have got escalating, changing needs, mental health needs, social health situations, or the vulnerable, where a provider might be not sure if things are well coordinated, or if a service provider might not be sure who is involved in a person's care. They can refer through to us and we can have a look at that and work out the best way forward.
Yeah, and often services that refer in, you know, once we, I guess, investigate and do a bit of work, we often find that there's more than one service trying to do the same thing for the person in whānau. So it is quite good to, really work with the group to determine whose role is what and the importance of that.
So when we get a referral, so the person is identified by whoever the referrer might be, and the referrals can come from far and wide. They come from primary care, from general practice, they come from secondary care, St John, we've had referrals from corrections, Alzheimer's. We are quite connected with our housing, with this Christchurch Methodist Mission, Housing First, Sustaining Tenancies. So we quite often get referrals from there. So very broad. We get referrals from the Care Marlborough, which is the advocacy service for mental health. So any service or provider can refer through to us. When we get a referral, we do a little bit of background work to see what other service provider might be involved in their care. And then we identify the pathway. So we get together as a team, and then the pathway can either be, we will look towards having a care coordination meeting, or we might be connecting them with other services, providers, sharing information between the team, connecting them together, or else it might be for advice or information. So that's sending some information and advice back to the referrer that they'll be sharing with the person that they've identified. So connecting, Renee, did you want to talk
Yeah,
about
and I think with the integration of Hei Parakiki, our referrals are now coming from our LMCs because they're identifying early of the vulnerability of what might be, and also Plunkett and our public health nurses. So that's been by expanding, I guess, care coordination to every age. It's really opened up our reach, I guess, and more services are referring.
So our approach, we're really, wanting to have is reducing health inequities, and care coordination is a way that we can help with that. We're supporting proactive identification of people. So that's, for example, using the dashboard within Datacraft with our general practice teams. And then of those people that might be as a predicted high risk of presenting to the hospital. We support practices and providers to identify people at the earliest opportunity. So we do quite a lot of meetings with our providers so that they're getting to know the service really well, getting to understand the service. And the more times that they perhaps have even been involved in a care coordination meeting, the greater that understanding they've got and the referrals we have coming through. Strengthening relationships, because sometimes providers can feel they're working in isolation, and it's a great way that they are supported as a team member as well. With the interdisciplinary team meetings with the patient, they are actively participating in the meeting. They're sharing the information with the team, and they're actively developing the care plan with their team. And that can be really empowering for them, and it's certainly a great way of the whole team and the person and the whānau together developing the plan that's around the patient-centred goals. For us, the three of us as a team, we're all part-time in this role. So we do work from a strength-based approach, and very much we're a team, and we work as a team, we support each other as a team, and we have got a wider team with our Nelson colleagues that we meet with monthly as well. We continually reflect on our practice, review what we do, evaluate what we do, and this care coordination just continues to evolve, and we're really passionate around care coordination. Renee has come into it, and she's more around admin support as well. My background is I'm a registered nurse and Bronwyn's social worker in ED. So we've got, we really work to each other's strengths and support each other. So when we have a care coordination meeting, so we identify that is the pathway forward for the person. We look at who's involved in the person's care, so that circle of care. So obviously this is a consented process, it's not an urgent process. So setting up the meeting can take a little while, up to perhaps a couple of weeks, because we're really important that we have the right team members there, the whole team members there, and general practice need to have a little bit of time, as much time as possible, for them to be able to link into our meeting. Often the team members generally always have a relationship with the person who are part of the team, and we also reach out to the team themselves to identify, is there any other person in the team that needs to be invited to the meeting. Before we even get a referral, if we're talking to somebody who is thinking of referring to care coordination, it always is a consented process, and what's important to the person and what their goal is, because that guides the care coordination meeting. And it's really important that we have that. And if we don't have that, we will go back to the team to find out what's important to that person and what their goal will be. A care coordination meeting, we have that either by Zoom and or face-to-face, and they last for an hour maximum. But by that time, everyone's had time to share information, and they've developed the plan. Our role in the meeting is to facilitate and to coordinate the meeting. We write up the meeting notes and get them out to the team pretty much within 48 hours or less, and that goes out as a draft to make sure that we've captured the information correctly and not missed anything, and then that gets finalised out to the full team and the person themselves. Often the meeting is just the beginning of the process, and the connection and the supports that happen after the meeting, that's part of the care coordination process. We check at the meeting whether the team are happy for all their contact details to be shared, and they always are, and we have those in the meeting notes as well, so they've got that information around connecting afterwards. It's just the layout of our physical layout when we have our meetings in the meeting room. Very often the person and their family might be there with us. So it's quite a skill facilitating the meeting and making sure that the person's well supported, that there's other members of their care team there as well. And we've got a whiteboard, and on the whiteboard we write up care coordination meeting for whoever it is. We write up what's important to that person and their goal. So that's there with us at the beginning of the meeting till at the end of the meeting before closure. We go back and we check that that have we covered that off? Is there anything else that we need to be talking about? And that the whole team and the person and their whānau feel comfortable with that.
And I think that's quite good, because sometimes in meetings, you know, conversations can get off track a bit, and I think it's quite easy. So having that board there is easy as facilitators to get the conversation back to the person and what the goal is for the person. So that's really handy to, as a facilitator, to keep the conversations on track.
We have really good presentation at the meetings. We have very few people that decline, and if they do, they'll probably send us some written information to share with the team, and then the team can also provide information back to that person. We've had the most recent meeting we had on Friday was the person and her family member. The GP came in, St John came in, and we had ED, SMO, and we had the surgeon. And the meeting didn't last for a full hour, but we got a really good plan that the person themselves participated in developing. And so I think it really shows that they're finding it's a really supportive process.
So we just thought we'd throw you an example of one of our recent care coordination meetings. It was for a hapu mama in her 30s. She needed care and support, vulnerable, unstable living situation, and she self-referred herself into the service. She had been through us before at a previous meeting, so she knew what the service was, how it could benefit her and her care team. So what was important to her was for her team to keep supporting her and to stay on board, and for her to keep off drugs. And her goal was to be a good mother and care for her unborn baby. So as you can see here in the blue, these are all the services that came to support and came to the care coordination meeting. And as you can see, especially for a hapu mama, you can see how far and wide our reach was. It wasn't just, you know, health services, it was a lot of social government agencies as well.
And just so we have Women's Refuge, we had the Christchurch Methodist Mission, Housing First, her general practice, MSD, OT, alcohol and drugs, mental health, ED, and the social worker. So that these were all the care team members for this person. And the other services and providers that you can see there are all services and providers that we have had that have become part of the care coordination in some way over that 6-month period.
So the outcome, I guess, for this patient was that the team could coordinate, communicate with each other and develop a plan that everyone contributed to, especially for the patient, and they were able to work together.
It's not a quick fix, because these people are complex, high needs that we get, and it's but it's a way of the whole team connecting and communicating with each other and with the person and the family, and also themselves, the whole team feeling supported as well. So we've got challenges. IT is quite a challenge. Systems that don't talk to each other. UMS form, which is what we get our referrals from general practice, it isn't set up very well in the fact that it hasn't got somewhere that they can write what the patient goal is and what's important to them. So if that's not in the body of the referral, we just need to double check that. So supporting teams towards the person finance-centred care was a challenge at the start, but the people were becoming far more familiar with that. So that's probably less of a challenge. I guess our reactive health system is a challenge. So really wanting to support general practices, secondary care, but when they're so busy with things that are right in front of them, it's how we do that and the pressure in the workforce. But we want to be as practical in our support for the practices as we can and for the whole team. So this is it for us looking ahead. So we're really wanting to grow care coordination and our care coordination approach. We do a lot of networking, as I said, with NGOs, community social providers, getting the message out there that refer to care coordination for anyone that you are concerned about. So our focus for our general support and the wider care teams of general practice, we're looking for a pathway to support unenrolled population with complex needs. Strengthening our networks, always building the connections, extending our reach. And more recently, we're working around a pathway for people with MND or progressive neurological disorder. So we've spoken with a physician, and the physician has been to some of our care coordination meetings and thinks it's a great idea to look at the possibility that it might be offering a care coordination meeting for people who may be newly diagnosed with that, yeah.
Yeah, with the pathway for unenrolled with complex needs, we have developed a pathway. We've worked with our maternity services and general practice to look at our unenrolled hapu and our pepe. So we have developed a really supportive pathway for enrolment and connect with services, but it is looking at those unenrolled, other, I guess, patients out there with high complex needs.
We are fortunate that we've got our colleagues in Nelson as well, locality care coordination, and we do meet with them monthly. And so it's great because it's another way that we're sharing ideas, new learnings, what our challenges are as well. So just take-home messages as just the importance of patient-centred goals when we have our care coordination meetings, and the goals can be quite small, and just the way that empowering, enabling and supporting our services and providers to work together in collaboration rather than isolation, and that's really important, especially for a lot of our NGOs who may not have the contact with other organisations and services, and coming together in a care coordination meeting, they feel supported as well. As we said, care coordination is often just the beginning of the process, and our reflection and that we do regularly all the time with what we're doing, seeing if we can make it an improvement. And we're just really, really be interested to know what's happening out there in the wider world around care coordination. We'd love to know what other places are doing and what we could share and get new information.
That's great. Thank you, Renee and Megan. It's just so interesting to hear what you guys are doing. If anybody has any questions, feel free to pop them in the chat or put your hand up. I did have a quick question. You were talking about patient A, obviously self-referred. Where do you find most of your referrals are actually coming from? Is that from you guys, sort of looking in the Datacraft information for patients, or?
They've all come, no, probably our referrals have come from a wide range. So probably general practice, secondary care, ED love it. ED refer a lot. General practices refer, mental health services refer, we get a lot from them. We get, as I said, from the housing first, sustaining tenancies, Christchurch Methodist Mission, and then other providers. We get them from Weidenfeld Corrections, St John, they refer in quite a few.
And I think on top of that is that it's identifying services that, really work with our vulnerable and our complex patients. So it's identifying them and then building a relationship with that service. And so it's regular network meetings. The more that we can support them and go to them, the more that they understand the process and the more that they can see the service supporting them and their patients.
That's fantastic. Ronte, you've got your hand up there.
Kia ora koutou, ko Chantal Kiwi, Kiwi Tōku Ingoa. I'm change lead for Collective Action with Communities, and I've met most of you online before, but aroha mai, I missed the very first part of the first session. Thank you so much, Renee and Megan. It's really awesome and really inspiring to hear about how you've every step of your mahi. Just thinking about those challenges that you mentioned and with the pressures on the workforce and bringing together all these different groups of people, service providers, how do you ensure that you have a safe space for whānau that come in into these care coordination hui?
That's working with the referrer beforehand during that process, making sure they are supported. An example might be a person that we had a care coordination meeting for, and she was in her home. She had a lot of family in her home that she was looking after. So Te Piki Oranga went out to her home and they zoomed in from there. So she was supported in her home environment.
Ka pai, ngā mihi.
Yeah, so like we said before, we're really interested because, we have our colleagues over the hill, and we know that there are probably a variety of models of care coordination and what this looks like. And, there's probably models that are very practice focused or within practice. So, yeah, really happy for anyone to kind of reach out and let us know what's happening in their rohi so we can kind of get a bit of a gauge and I guess just build connections with each other as well.
Which has been a really, really awesome.
Yeah, I think that would be great. Did you want to pop the best way to contact you guys in the chat, Renee and Megan? Yeah, because I think it's probably one of the sort of great things coming out of like the Leads Days and the peer sessions is, people across the whole country are being more able to, see what the other practices and PHOs do and being able to connect more. Because I really think, and with the health reforms and localities, like it's definitely the way forward. And sort of why recreate something from the ground if somebody else is already sort of perhaps working on the same thing, like working together. It's all the way forward. So does anybody else have any questions for, sort of the collaborative? Nikki, Renee, anyone else online? I mean, you've got all of our contact details if anybody does. So it looks like we are all wrapped up today. I just want to say thank you to everybody that came along to listen. It's great to take time out of your day to attend these, and thank you for everybody that presented. It's always great, hearing from new people and places and about different topics. And if anybody is doing,
because I think the
that you do really would like to share with everybody, just get in touch with myself, or we see we can organise you to come to one of the other peer sessions as well, because this is, you know, all about sort of getting together what works for you guys. You know, it's not all what we sort of think should be distributed, but what you guys want to see as well. So just thank you all. I will wrap up with a karakia. Let me just share my screen. Oh, look, now I've broken it. Okay, can everybody see my closing karakia? I hope so. So I've got he karakia whakumutanga. Cool. Right now, I apologise. Just before I jump into it, this is quite a new one for me. By Dave Coyne, I think it is. So I just apologise for some of my pronunciation. So I've got ko ranginui I tunei, ko pepa tuanuku e tukuru nei, ki tau tirangi marie, ki runga e te tātou mahitahi, homie, huie, takie.
Taiki.
So thanks everybody for coming and enjoy the rest of your day, and we'll see you next time.
Kia ora, ngā mihi.
Kia ora, everyone.